John, I'm surprised you haven't commented. I dressed up for the podcast today.
Oh yeah, it's a clean T-shirt, right?
I wore a jacket, John. Now, John, last
Oh,
night,
well, I thought. Okay.
speaking of mental health crises, Simone Biles stepped out of the last Olympics, but last night she was dominant and
She
back.
was on fire and did USA proud, did herself proud. Uh, it was a tearful moment. Jack, I don't know, are you an Olympics guy?
I'm not, but actually Simone Biles has driven a lot of interest, and I speak a lot about her, especially when I talk about self-care for healthcare professionals, right?
Oh yeah,
Being bound
absolutely.
to supporting our team, knowing that our own performance, how it's impacted by our own fatigue, our own stress, our own mental health issues, and that sense of if we blow it, it's actually can be incredibly dangerous.
Wow.
That's
Yikes.
that's
Yeah.
that's her story, and it's ours too, Jack. Thank you.
Well, John, and that gives you an insight into why this 20th episode, I wore a jacket, John. It's Dr.
Okay,
Jack Rozel. Let's get it going.
let's do it.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
So, welcome back to the 988 Lifelines podcast with David and John. We're coming at you from the heart of Atlanta. I'm missing my Atlanta t-shirt today, but it's expect a new one next week. But John, the water's warm if folks are crisis workers or crisis junkies like we are. And yet we're also very conscious of the fact that the experience of crisis care can be a splash of cold water in the face for those who are in pain. And Dr. Jack Rozel, a lot of that experience comes from this issue, our fear of the violence that we think might be associated with mental health, and that's the reason we do the things that we do in mass. And yet, it's also a real issue that we must grapple with. So, John, tell us a little bit about our guest today.
I'm so excited to have you here, Jack. Dr. Jack Rozel is a national expert in forensic law, threat management, and violence prevention. Jack, also the past president of the American Association of Emergency Psychiatry, a law and psychiatry professor at Pitt, and the director of the Response 988 Crisis Center in Pittsburgh. We are so happy to welcome you here today, Jack.
All right, thrilled to be here.
So, John, we hope everybody will watch us on YouTube, like and subscribe, and or wherever you get your podcasts. So, Jack, the way we like to start the each episode is to learn a little bit more about you personally. Maybe you could share with our audience something that folks might not know.
Sure. I think it's worth talking about how I got where I am today, right? When I was in high school, I was kind of a, EMT nerd, hanging out with, the ambulance folks and things like that. And when I hit college, I'm like, oh, I think I'll probably go on into emergency medicine, maybe critical care, something like that. And I had the luck and frankly, the privilege to have the bandwidth to be able to do some volunteer work when I was in college. And for the entirely arbitrary reason that on the bulletin board that was closest to my dorm room back at Brown University, there was a sign and it said, answer the call for the Samaritan's Hotline, which was a suicide hotline all over the world, but also back in Rhode Island, that was conveniently like a block and a half from my dorm. And so for that entirely rational, well thought out reason, I ended up volunteering there. And I don't want to say they didn't train us, but it's hotline volunteer training. It was 30 or 40 hours and a lot of observed shifts. But I remember this moment in the first couple months, sitting there on the phone, and I'd been on with someone for 5-10 minutes, and I hadn't said much more than and what was that like for you? And it made a big difference in this person and helped them sort of turn the direction.
Yeah.
And I remember sort of thinking, like, my God, imagine if I really knew what I was doing. And here I am, a lifetime, almost 35 years later, realizing that's the most important part is just to sit and to listen and to be respectful with that other person. And it's not the only part, but if you're not doing that, then the likelihood of you making any progress in any other direction is slim to none, unfortunately, at least in my experience.
Yes, listening with intent.
John, what a great tie to the last episode. So the last episode we said, don't do something, just sit there. And
Yeah.
today we're going to say, don't just sit there, do something. And Samaritans, let's come back to that because, John, that was part of our development of the guidelines for emergency intervention, what we called engaging those at higher risk. So, but Jack, I still feel like I don't know you as a person. And here's the thing. The next thing we're going to do, John and I we either have to know you or we have to cheat and go onto Facebook or Instagram. And I couldn't find you there either.
So yeah, I have no Facebook presence. I have a professional Twitter that I share with the wonderful Dr. Delilah Solomon at Violence Walks, where we tweet about sort of violence policy and research and things like that, and sort of current events. And it's kind of a dark thread to follow. And then I have my own sort of private masked one that's basically puppy dogs and kittens and
puppy dogs and kittens. So John, So now you didn't give us much with the personal insight. It's helpful for us to understand your career trajectory. Great.
Yeah.
But personally, we're going to guess now. So we call this the super fan segment. John, what are you a super fan of?
Oh my gosh. A huge football fan. We were just about to launch football season. Last night was a Hall of Fame game. So here we go.
Yeah, I'm embarrassed, Jack, but I'm a super fan of UFC. It's only been about 10 years ago. I wouldn't watch boxing from a moral position, so I don't know what happened. But what is Jack Rozel a super fan of?
All right, here we go.
John, and Jack, you're going to tell us, did one of us win? There's got to be a winner or a loser.
Here we go.
Or neither one of us were close. All right. I know Jack's from Pittsburgh. All right, I got a shot. All right, I'm ready, John. What do you got?
Here we go.
Let's see yours. Cooking. John, and look, you finally came up with, you had like 3 answers last week. Cooking's a great one. Now, before I show mine, Jack, is that warm?
That's excellent. Yeah, that's pretty much spot on.
Okay, all right. I've got mine. I think you're a super fan of the Pittsburgh Steelers and Terry Bradshaw in particular.
Wait. Did you just drew that, David?
I'm fast. So Terry Bradshaw or cooking, is there a winner today, Jack?
It's hard to go against the state religion that is bleeding black and gold, which, again, as a physician, you should not be bleeding black and gold. Get yourself checked out if that's your situation. But, as far as what do I do for my own recovery time, it's a lot more likely to be in the kitchen than watching people cause TBI.
Wow, look at you.
You seem to be a master of fine cuisine in my mind. I can just see you. I can see people saying, yes, chef, to you in the kitchen.
John, was that a total guess, or did you have some?
That was a total guess.
Come on.
There's something about Jack that I think this guy, I want to eat with this guy. I think I want to eat at his place is really what I want.
There was a low point in med school where I thought about, hey, maybe I want to work in the restaurant business instead. And I had a good friend who ran a couple of wonderful restaurants in Providence and let me sort of hang out with his kitchen team. And I decided I didn't want to work that hard. And so here I am in emergency psychiatry instead.
So Jack, if you were asked that question separately, what are you a super fan of? What would you have said?
Wow. Cheesy science fiction, good bourbon, nice mellow cigars. So
okay, great, excellent.
Man, I love that. We need to hang out a little bit more. I want to eat at your place, and then we'll have bourbon and cigar. That sounds like a great idea.
So John, this episode with Dr. Jack Rozel is brought to us by our sponsor, Behavioral Health Link. Tell us a little bit about the crisis software platform, or what are you bringing us today, John?
Oh, I'm happy to talk about that. Jack knows about it because we brought Jack in as a consultant to help us build an evidence-informed violence assessment tool for our call center module. And the work we did with Jack and Dr. Thomas Joyner, Dr. Chuck Browning, and many other crisis service experts to build a software platform for call center counselors, I think, is a real game changer. Now, David, you know how our call center module allows counselors to put the relationship with the caller first, enabling the counselor to listen to, connect, and collaborate with the caller while seamlessly collecting the required data they need to best help the person in crisis. Yes, it does that, but the platform also acts as a co-pilot for the counselor to guide their assessments and collaboration with callers in ways that are aligned with best practices, with tips, guardrails, and alerts that help the counselor stay focused on effectively addressing the needs of every caller. Now, because BHL develops software as a provider of excellent crisis services, we're dedicated to continuously building best practices into the DNA of the BHL platform as our field learns and evolves over time. You can learn more about how your crisis center can evolve with our technology at behavioralhealthlink.com. David?
Terrific, John. Thank you. And thanks to our sponsors. So, Jack, our next segment is the good news. And we got a couple of items today. First of all, I have in the mail my trusty, I don't know, did this come from FedEx, John? Let's open it up. And it's a copy of Rory O'Connor's book, When It Is Darkest. So my son actually is doing speech and debate this year. He decided to do a prepared speech on suicide, John.
Oh, really?
And he read Joyner's Why People Die by Suicide and Myths About Suicide, and he watched our documentary.
Wow.
And a host of other things. And he said, what else should I be reading that I haven't read? And I said, Darkness Visible. And I said, I haven't read it, but Rory has a new book. So my son read the book and said it was terrific. He landed up leveraging this more than he did any of the other materials. So
Really?
John, let's pursue. Can we get Rory on this podcast?
Oh yeah, no, I think we've got him nailed down. I think he's invited to come.
Let's try. Let's say.
Yeah, no, Rory's out.
John, have you read it yet?
No, I'm dying to. And
so let's go read it, John.
Yeah, Rory is super smart. He's super compassionate, and he knows all about this subject. I think he's a really nice add-on to what Thomas Joyner's found. I think they're kind of flip sides of the same coin.
Yeah.
So you kind of need to know both of what they've talked about to understand why people kill themselves.
When It Is Darkest. And of course, John, the other thing that we're doing is the first documentary we made, 6 stories from the United States, with the narrator, the thread that goes through it is Dr. Thomas Joyner.
Yep.
We're now making a sequel. We've already filmed in Australia, in Brazil. We're going to Indonesia.
Wow.
We talked to a young woman from Mexico City yesterday as we're casting, if you will, and talking to storytellers, people with lived experience. We're hoping to have an Inuit person from northern Canada, John.
Ooh,
so
wow.
Rory would be interesting as a potential narrator for the second film.
Ooh, that's
let's read this book and talk about that more, John.
Yeah, I love it. Great idea.
The other good news, John, is look, Jack, you were joking a little bit about we've got this good news of 988. Well, it's 2 years old, Jack, as you were sort of alluding to. And Politico gave a little bit different spin on the growth. So, John, this is May of 22. So these are calls to the 1-800-273-8255 National Suicide Prevention Lifeline, the chassis on which 988 is built. And over 2 years, John, 988 has added a very significant volume to that, up 80% in 2 years. John, reflect on, you spent your career building the foundation for 988. John joined us right after the launch. Talk about, John, that growth, and Jack would be interested in your thoughts as well.
Yeah, I think obviously it's always about awareness. And in this case, it's also about an easier to remember and dial number. So it's easier to remember, and it's also easy. I'm not sure it's easy to talk about for people. And I still think that, the messaging that's coming out of SAMHSA right now is significant, and the campaigns that have started are going to make more of a difference. But I think what we know is that if we can get it if we can get messengers that people trust to talk about how important this line is and what it means to them, that more people are going to call. But David, yes, it's significant increase, but there's still some 75% of the population that has no idea what this number is. Yeah. So to me, this is just the tip of the iceberg. We're moving in the right direction, but we have a long way to go.
Yeah. Jack, what do you think?
Yeah, public awareness is just a vital issue for accessing these types of services. And I remember those early conversations we had back at those SAMHSA meetings. Just a couple weeks ago, I was at a board meeting of a local major behavioral health organization. And I said, okay, show of hands, how many of you know the 10-digit phone number for Resolve Crisis Services, our local crisis center that's part of the Lifeline network that has been doing crisis services in our region for 15 years. And like 3 people out of 15, almost 20 people raised their hands, and 2 of them because they had it programmed into their phone, which is great. I'll take it, right? And I wish 100% of them raised their hands when I said 988, but 100% of them didn't, right?
Yeah.
And this is like these are experts, like these are pros. These are not just random folks off the street, right? And so we have the awareness issue. We have the, we got the 988 approved and passed in Congress, and it was kind of the metaphor I always use. It's the dog that actually caught the car, and we got it, and now we've got to build up capacity nationwide to be able to handle the volume of people in need, especially knowing that most people don't know about it, right? If we go out to a restaurant later and I choke on a pretzel, like people know the Heimlich maneuver, people know to call 911, like people understand that, right? That's part of the culture that we've grown up in. We're not there yet. If I'm at that same table and saying to my friend, I can't do it anymore, I can't take it. Like, you don't know who to call, you don't know what to do, and hopefully we're at an inflection point for emergency mental health today, just as we were 60 years ago for emergency medicine when we were first getting 911, when we were first getting paramedics instead of the funeral director or the coroner to respond to the motor vehicle accident on the side of the road. Like, how could they possibly be motivated in the wrong direction, right? The creation of a specialty of emergency medicine. We're on the precipice of, maybe having something for emergency psychiatry. So we're not where emergency medicine is in 2024, but I think we're a lot further than they were in 1964, and I think we're going to catch up real fast.
So, Jack, that inflection point you're talking about, one of the things that came out in this Politico article is it does vary by state on how much it's grown. And Oklahoma, not coincidentally, was the highest at 185% growth. Oklahoma has done some amazing work in the space of promotion, John, and we've had some of their leadership on the Crisis Jam. We ought to get them into this podcast. But Jack, let me ask you this. That growth is that we are seeing as people do learn about it, I think is coming from a variety of areas. It's coming from people who learned about 988 and they didn't have to go to their phone for that 10-digit number to your center. So they did 988 instead. Now, that didn't make any difference to you because it's just someone who was calling you anyways, calling you on a different number.
Right.
But someone else was calling 911 before, and they called you instead. And that might be different because the acuity there, the challenge of that call might be higher. Yeah. In fact, we know on average they are higher. Not every one, but on average, that's going to change the composition as calls that historically would have gone to our emergency public safety system are coming over to Rozel.
Yeah. So, there's a little bit of that, right? So the pendulum is swinging a little bit, but I think the pendulum's going to swing a little bit back, right? Because the calculus someone has to go through to pick up the phone and call 911 and say, I'm in crisis or my loved one's in crisis.
Right.
Who comes to the door matters, right? And in most jurisdictions across our country, the call taker, that 911 center, they've got to make a decision. Is it going to be a firefighter? Is it going to be a paramedic? Or is it going to be a cop? And if I don't know, it's going to be a cop. And getting that like fourth box of disposition and on the radar of the 911 centers, we all know what an uphill battle that's been, but that's sort of the brass ring we're reaching for. But in the meantime, it's likely to be a cop. And I can think about sort of the implications of a cop showing up at my doorstep, of a cop taking me to the hospital. And I am, as I appear, with all sort of the privilege and social context that goes with. And if that keeps happening, what does that mean to my neighbors, right? What are the risks to me if I'm in crisis? Yeah. We don't worry about someone who's having, a heart attack or a diabetic emergency ending up in handcuffs or jail,
right,
or the morgue because of police response. We do have to worry about that with behavioral emergencies. And so I think as people get more used to the idea of, calling because you need help, one of our mantras over at Resolve is, call before a crisis becomes a crisis, right? But no one says call 911 because things are right? So hopefully we get to the point where people are calling 988 before it's a crisis, when they need the support, when they need the help. As my bomb squad buddies always say, it's better to be called in when the timer says 6 hours than when it says 6 seconds, right?
Yeah.
You have a few different options.
Yeah, and I think you're right, Jack, that that a lot of people have been calling 911 because they're saying, I'm feeling an emergency here. But if they understand that the choices of who's going to show up to what you're feeling are made very explicit and clear, and some 911 centers are doing this. When you call, people get the initial message in some locations that say, do you want police? Do you want fire? Do you want medical? Or do you want mental health? And that helps people get a sense of like, okay, I don't want police. I do want mental health.
Yeah.
So if you give them a multiple choice, more often, certainly people with behavioral health crisis are not going to want cops to show up.
Yeah. And I absolutely get why, our PSAP partners have, what they're trying to balance and deal with. But we'll get there.
Yeah.
We're making progress.
John, you were going to ask about Jack's origin story. He gave a little bit of that.
A little bit. But Jack, your trajectory after the Samaritans goes well beyond. I mean, not everybody who works at at a crisis center says, I want to be a psychiatrist. And not a lot of them say, I want to be in emergency psychiatry. And a lot of them say, I also want to go to law school and get involved with forensic psychiatry. And these are particularly high risk and specialized areas of psychiatry. Yeah. So tell us about what led you down the pathway of these really high risk areas where forensics and emergencies are very much a part of the picture.
Well, one of my first bosses in emergency psychiatry after I finished residency said emergency psychiatry is probably a lot more like emergency medicine than it is like the rest of psychiatry. And I think he was absolutely spot on about that, right? And I can remember, again, sort of, back in the day when I was sitting on that couch and answering the call at the hotline. And I remember, I noticed, over a couple shifts that probably half, maybe 2/3 of the folks who were calling in were spontaneously disclosing a history of violent victimization, physical abuse, sexual abuse, child abuse, something along those lines. And then I sort of, on my own, did my own sort of experiment of just some gentle inquiries. And when you did a little gentle probing, more than 80% of the folks. And so I started getting really into that. Like, what if we sort of move upstream, right? What if we start understanding what's leading to these people being hurt? What's leading to people being traumatized, and what can we do to manage that? And that sort of brought me more towards this interface of suicide and violence risk. And again, it sort of fits into that adrenaline part of me that does the emergency stuff. And so that's sort of where it's been at. And, the other thing I'll say about emergency psychiatry is we juggle and work with legal questions routinely in what we do. Does this person have a right to walk out the door, or are we able to keep them here with us, right? Can we violate their confidentiality and share sensitive information that they've shared with us? Can we share that with other folks to prevent a violent act from occurring, right? So there's all these really interesting questions that sort of swirl together. And, over the years, that's sort of been my space of sort of violence and suicide and emergency stuff. And as I'm sure many of the listeners know, when you spend a lot of time in the emergency mental health space, part of what you end up doing is you respond after the bad event. That you get called out because there's someone in the community, there's a first responder, there's a family member, and something just awful happened to them. And maybe it was something that just happened to that family. Maybe it was something that impacted the whole region. And you're there for them. And you work with them through that crisis and hopefully hand them off to longer term services if that's what they need. And did a lot of that for mass casualty incidents, mass violence incidents. As a child and forensic psychiatrist, I spent a lot of time working in juvenile justice settings, and so many of those young folks have witnessed and survived gun violence. And I realized some time ago that I'm good at that, right? I'm good at that acute trauma stuff. I'm good at identifying and treating PTSD. And I don't know if I can drop the F-bomb here, but I'm just tired of that. I'll still do it. We'll always do it. But I've gotten a lot more interested in how do we prevent it? How do we stop some of those awful events from happening?
Well, we were so close to getting our first real swear word on the podcast, but Jack pulled back. So Jack, we work really hard. We want to make this fun. We're never putting our guests on the spot, but tell us, which is better? AAEP or ACEP? Which is better, Jack?
So ACEP, they do great stuff. They're there for the emergency physicians. I am absolutely humbled that I'm the first psychiatrist who's ever been a member
Tell
of them
everybody
as
what they
an
are,
honorary
though.
member.
I'm not sure everybody knows what
Oh,
ACEP
sorry, of
means.
course. So the American College of Emergency Physicians, this is the organization of emergency physicians for emergency physicians. After doing a lot of, like I said, responding to people who've been traumatized, working with so much of their membership through COVID, which hit them horrifically hard. They were kind enough to sort of bring me in as a member, right? So lots of dear friends with them. The American Association for Emergency Psychiatry, despite the last letter of that name, we are expressly multidisciplinary. We have emergency medicine docs, we have emergency psychiatry docs, we have psychologists, we have nurses, we have social workers. We want people who are invested in behavioral emergencies and bringing compassionate, evidence-based care to those in need in a systematic way, and building the networks and partnerships necessary to do that. That's what our organization is about. And absolutely, emergency medicine physicians and ACEP leadership is a big part of what we do, and hopefully we're a big part of what they do. Because here's the thing, right? Like I said before, if you're in crisis in our country and you pick up 911, odds are pretty good it's going to be a cop who knocks on your door. And most of the time that goes well, and a lot of times it goes incredibly well, and sometimes it goes awful, right? But also the place you're most likely to be brought is not to a recovery-oriented crisis center like we have here at Resolve. It's not necessarily going to be a mobile crisis team. You're likely to get brought to an ER. And again, that's a great place to be if you've got an imminent medical emergency, and you've got to be there to decide, is this a medical emergency or is this something else? What do we do to keep you alive? But it's a tough place to start that pathway to recovery, right? And if you're boarding and waiting for an admission, living with that first psychotic break, that relapse of your trauma on a bed in the hallway for hours, sometimes days, sometimes weeks, it's rough, right? And as good of a job as EM physicians do for a lot of these emergencies, the reality is that their required training on psychiatric emergencies is zilch. Now, by the way, probably a third of their volume is people with, active psychiatric issues in some way, shape, or form. 20 to 30% probably.
Holy smoke, Jack!
But it's tricky, right? And emergency medicine physicians are superb at doing the first 15 minutes of every other specialty, including psychiatry. But when they're faced with patients boarding in their ERs, like I said, for hours and days, that's a lot more than 15 minutes. And it's disruptive in the recovery and the lives of the patients and their families. It's disruptive to the ER systems and everything else that happens around them. It has a lot of ripple effects.
Jack, I've had so many tremendous mentors in the crisis space, but Sandy Schneider, Dr. Sandy Schneider, past president of ACEP, has shaped my thinking. And you referenced a lot of it, that the emergence of a professional and scaled and accessible emergency medical response system is the analog for us. But that came from her. And I just, it's just tremendous to have an emergency room doc like that in our space. So
part of Dr. Schneider, and part of our sort of our shared history is she and I, we sort of followed each other around. We were both at University of Pittsburgh Medical Center for a few years. Then she went to Rochester. Then, after I finished residency, I ended up in Rochester. And so we've always sort of, had this parallel orbit. But going back in the day here in Pittsburgh, going back to the 1960s, was this great thing called Freedom House. And that was where an anesthesiologist went up to this great program in the Hill District, a majority Black community here in Pittsburgh, and took a bunch of folks from the community, from one of their community resource centers, and taught them to be paramedics, right? Right. And before that, again, if you had a medical emergency, and part of what inspired what they did with Freedom House was that I can't remember, it was the mayor or the governor had a heart attack at a local event, and they basically threw him in the back of the paddy wagon and hauled ass over to the local ED, right, without doing anything on the way. And so they said, hey, we can do better. And we can do better. They took good people from the community. And by the way, some of them were actually medics, military veterans who'd served as medics, and they taught them to be paramedics. They taught them to intubate. They taught them advanced resuscitation. They taught them how to respond to the community. They gave them vehicles that were designed to purpose. And that was, again, the beginning of what it was to be a paramedic in our country, the first real standard. And here we are 60 years later, and we're trying to come up with those same standards for our phone clinicians, for our mobile crisis teams. And it's really, really an exciting moment. Because again, 60 years ago, a lot of times it was the cop or maybe the medical examiner or the funeral director who responded, if you wrecked your car and had a broken leg on the side of the road. And I always think about that scene in Monty Python and the Holy Grail and, bring out your dead. And the guy's like, I'm not dead yet. And, you will be in a minute. Like, do me a favor,
you
knock
will
him on
be
the head. Right? Where's the incentive? And today, as good as paramedics are, they get paid to bring the person to the emergency department. That's how they bill. Yeah. And so that means the model is, let's bring them to the hospital, which is, again, it's great because hospitals can do a lot of really amazing stuff. But there's a lot of stuff that's crisis that doesn't need to be in an ER. And so finding ways to effectively, safely, successfully work with folks in the community to help them not just survive, but to thrive at those lower levels of care is I think really what we're trying to do with crisis 2.0 or 3.0 or wherever we are in the numerics.
Yep. Love that. And Jack, so, we really want to lean into your expertise around violence and threat assessment. And as we develop this next generation crisis system, what is the right interface with law enforcement in particular? So it brings us to our trivia question for the week. And we do an over-under here, Jack. An over-under question where I'm going to ask John Draper, I'm going to ask Brooklyn here a question. He's going to give us a number, and you're going to say if he's high or low.
All right.
So, John, let's go to, in terms of when we're talking about risk assessment, let's talk about the landmark Tarasoff case, John. The Tarasoff versus the Regents of the University of California. That landmark case originating in the late 60s, early 70s. And it requires clinicians to go beyond the practice that used to be the case. And it now says, if we have meaningful evidence that someone's explicitly at risk, we've got to do more than call the police. We have to warn the person directly. So, John, the question is, how often annually does a clinician act upon the Tarasoff ruling and make a warning to someone? Now, John, we know this. We know the exact number because there are robots out there who can guess. So I've asked the robots. Now, Jack, every week we do this, and the robots always say, how would we know the answer to that? And then I press them. Well, use some logic. Think it through. And they always give us an answer. So, John, the question specifically is the low end of what the robot said is how frequently clinicians activate a Tarasoff duty to warn on an annual basis in the United States.
Yeah, I don't know knowing the number of clinicians, the number of people in treatment, let's assume that there's, some 30 million people accessing some form of care, including the crisis lines. And maybe.
All right. So, John, just to play it through, crisis line active engagement wouldn't have been caught up in this. This is therapists with someone in care. So you said 30 million people are in therapy or whatever. If that included people calling crisis lines, take the crisis lines out. This is your usual client, your counselor, your social worker, and they've been trained and they activate Tarasoff.
So this is annually. We're talking
annually.
About. Okay. I'm gonna give it a pretty low number. I'm gonna say because it's a small percentage of people that are violent, that are threatening, and that have the specific and that are in treatment. I would say in the neighborhood of 50,000.
50,000. I like that. John is so good, Jack. We give him these impossible questions, and he walks through the steps. How many people are in therapy on an annual basis? What percentage of them? It's a low number, but what is it? Jack, is John high or low?
So, here's the problem with the question. And maybe limit yourself to what's your understanding of what the terrace off duty is, David, John? What's your understanding?
John says he's gonna get me, and John's therapist calls me up and says we've got an explicit threat. It feels material. There's an intended target. That's my understanding, Jack.
And
John,
they can notify the police under these circumstances.
So, John, what did I miss? So, Jack, tell us: are we on the right track, or are we missing something here?
You're in the right direction, but you're way off target.
Okay, tell us.
Way off. Okay. So, and this is so. First of all, this is important because Tarasoff only ever applied in California, right? I know it's the answer on the multiple choice question on your licensing exam, and it's the one we all talk about, but it was a court ruling that only applied to California. And with all due respect to California Supreme Court, it was not the most clearly written opinion, which has led to a lot of the ambiguity. And every other state and territory has its own interpretation. Now, the broad pattern of there's a concern that there's risk of a person who's in mental health treatment is posing some type of a risk of harming a target. Right. And so the question is, what do you do next? Right. Now, everyone thinks that Tarasoff was a duty to warn. Right. That seems to be the impression here. That, hey, if we provide a warning, like somehow or another, that'll be protective. I have got a lot of footnotes to that one. But in fact, what happened was, the first time the California court reviewed this case in 1974, they said, yeah, there's a duty to warn. The second time, 2 years later, they heard the same case. Now, by the way, there's this thing called stare decisis. The decision stands, and I won't get into SCOTUS opinions, but when I went to law school, this was a legal concept that courts were supposed to say, hey, when you've made a decision, you stick with the decision. You don't change your mind unless you have a really, really good reason, right? There are some people on our current Supreme Court who have interpreted that differently. And by the way, so too did California Supreme Court back in 1976 when they heard the same case, the same questions. And they said, it's not a duty to warn. It's a duty to protect. And that may include warning, but it's a duty to protect when there's a specific immediate threat to an identified target, right? And in this case, the target was clearly identified. But the problem is that, again, it's a tough decision to read. It's a great case to beat the crap out of my poor law students with. And it was miserable to apply if you were a mental health provider in California in the 1970s. So the legislature came back and said, hey, we're going to clean this up and we're going to write a statute about this. But every other state has their own different version, either by statute or by court case. And it's kind of a mess to sort of know what to do. And that, by the way, is what makes it a friggin' nightmare for our partners in crisis work.
Jack, this is the reason. John Draper, let's quit having experts on this podcast. We need lay people. I tell you,
all we need is ChatGPT, Dave.
They mess up our trivia. So, Jack, let me just narrow it down. There is a study in 2010 in the American Journal of Psychiatry that estimated how often mental health professionals are, they said, issuing warnings under the duty to protect doctrine, like Tarasoff.
Yeah.
So that would guide the answer. So John's 50,000. Based on that, he's high or low?
I think knowing sort of, I think his estimate's probably not unreasonable, but I'm going to guess the journal article said it was lower than that.
So the journal article said, it didn't say how many cases. It said 1 to 2% of the time. Now, that's rare, but it's not as rare as I would have thought. 1 to 2% of the time of all therapy cases involving patients who pose a threat to others.
Yeah, so like I said, I'm guessing they're saying it's so if they're saying that's 4 therapy cases where there's a concern of risk, 1 to 2% of the time they're doing some kind of a warning, you get to a really low number because most mental health patients, most people living with mental illness, whether they're a patient or not, and by the way, it's not those people, it's most of us live with some kind of a diagnosis, right? By and large, not dangerous, not to themselves, not to anyone else, not today, not tomorrow, right? We're talking about a very rarefied, subset there.
So, Jack, I think I realize now that I did my math wrong on this. So the the answer that they have for the number of people in therapy overall on an annual basis is about 15 million. So of those 15 million, they're saying that 1 to 2% of those that pose a risk or talk about danger. So the 15 million subset, 1 to 2% of those, what's that subset? What's your guess of what that looks like?
I don't know. I couldn't do traditional outpatient therapy work. I'd fall asleep. And again,
I would guess somewhere in the neighborhood of 5%.
No disrespect to the amazing folks who do that work, but it's not for me. I don't even know. Like I couldn't even guess it. However, I will throw this out. I think the world is changing, right? And the way therapists may view this type of stuff in 2024 it might be a lot different than when that survey happened in probably 2008 or 2009.
Yeah. So, John, just if we followed your logic, 5% of 15 million would be 750,000, and 1% of that would be 7,500. So that's, again, 7,500 to 2%, 15,000.
I think that's, or you said 1 to 2%, so it could be, 15,000. Yeah. So that seems to me to be probably reasonable.
And look, and the other thing I learned is Jack knows his legal stuff. You said this up front, John.
Oh, man. Well, Jack has spent a lot of time investigating. I mean, you were talking about, I want to prevent these things. I don't want to be, as you like to describe it, dealing with things right of boom. You'd like to be dealing with it left of boom. Yeah. Could you talk a little bit about what those terms mean, investigating left of boom and right of boom, and what you've learned about prevention techniques?
This is the concept of the boom, right? Is something that I didn't learn in medicine. I learned it when I started working in violence prevention and this thing called threat management. And I think the term originates with the U.S. Marines or other military operators. And the idea is if you sort of imagine this timeline, right? Someone is building up to a bad act, some act of violence, whether it's that one person who's pissed them off or whether they're going for a body count, right? Boom is when the bad thing happens. And then right of boom, for a lot of my career, that's where we were called in. That's where we're doing the psychological first aid or the CISM work for the first responders or the folks in the community or the individual work, right? Boom is run, hide, fight. Boom is stop the bleed. Boom is that immediate tactical response by law enforcement or by, the proverbial good people with guns. And we could do a whole podcast on whether or not that's a thing. But left of boom is where we have a real chance to make a difference, to not just stop sort of the signal of that attack, but to divert that person who is on a pathway to violence and help, maybe when we do it right, to put them back on a pathway towards recovery. Right. And there's a whole schema out there of this thing called threat management, which dates back to the 1970s and attempted assassinations on Supreme Court justices. Make it all about the court again, right? That's been evolving for decades. And unfortunately, it's become the best kept secret that should have never been a secret. It is a blend of behavioral science, so folks like me with that sort of both forensic and emergency lens. It is criminology and law enforcement stuff. And it's draped over this really interesting infrastructure that we get from our partners in the intelligence community, by which I do not mean our psychologists who are doing IQ testing. I mean the three-letter agencies in DC and all over the world, right. Not officially declaring what three-letter agency they're with, but doing, secret agent stuff, right? Yeah. About how do we work with uncertain information and potentially dangerous situations, and how do we develop relationships with people who may not want to have a relationship with us so that we can better understand what their risk might be, right? And it's a really fun place to be for me as a mental health professional, because it meshes so nicely with a lot of how we think in emergency psychiatry. It meshes so nicely with the recovery model, which sort of surprised me. I was at a meeting in DC just a couple of weeks ago with, I don't know how we got invited to this, but it was an all-star cast of the leaders of threat management in our country. And I got to be in this room, and they sounded a lot more like peer specialists and recovery coaches and therapists than they did like, law enforcement and security and intel folks. And the focus was, how do we help this person? How do we find their strengths and build up their supports and get rid of their risk factors?
John, I'm so glad I wore my jacket this episode. We got secret agent stuff. We got F-bomb. Jack, as we're talking, the timing of this, lots of conspiracy theories about the attempted assassination of a president, but it sort of felt a little bit like the young man would have been as happy to end the life of President Trump as President Biden. What was your take as you were watching all this play out?
Yeah, so the location where it occurred was probably about 25 miles, north of where I live, and the town where I grew up was, not too far from, not too far south of me. And that evening, after it happened, as I'm sitting on my porch enjoying the cigar, but also sort of wondering when the phone's going to start going off, but also listening to the choppers going back and forth and knowing that some of those coming south were bringing folks for medical treatment, but some of those going north were bringing out the investigatory teams. There's a lot of groups investigating this, and I don't want to sort of speak to that.
Yeah.
But what I will say is that we have a generation in our country now. Everyone who's in high school, who's in middle school, who's in grade school, almost everyone who's in college, and almost everyone who's in grad school was born after Columbine.
Yeah.
Was born after this inflection point in American history where we realized that our students may be in greater danger, where there's this new thing happening of school shootings. And by the way, they're still very rare and they're still very awful. But where we as a society said, we're going to put more effort into controlling what the students can read than the guns that go in and out of those schools, right? And we sent a message to an entire generation of our country that if you're upset, if you need attention, if you need an interaction with the systems around you, one of the ways to do that is to be scary, is to put on that mantle of, I can be that scary kid. And sometimes the line between putting on that dress, that mask of I'm going to be the scary kid, and I will be that scary kid, I will do that thing, is very narrow. And that means we're facing a lot of these threats. And a lot of them, noise. Some of them, signal. And figuring out which is which is critically important. And again, part of the appeal of threat management is knowing that the signal to noise ratio is tough, and knowing that our ability to actually know which one of these kids is the one who's really going to do something dangerous versus which one of these kids is just not doing well and needing more support.
Right.
My interventions mostly are not arrests, are not involuntary hospitalizations. It's, hey, how do we understand this person? How do we help this person? How do we build up their social network? How do we give resources to that kid or that family so that they can do a little bit better?
Right.
And also realizing that if we snapped our fingers and every school shooting of every type and variation form went away, we'd still have 98% of the homicides of our school-age children in this country, because most of it's happening outside of the school. Right. And again, gun deaths are the leading cause of death for our adolescents, and it's just a small part of the overall puzzle, right? Yeah. Overall, gun crimes going down and violent crimes going down in our country. We've seen huge decreases, but at the same time, we've seen decreases for the past few decades in most types of violent crime. These types of mass violence are trending up. And again, there's this unfortunate secret that is threat management. That's a great tool for working with what we call targeted violence, where person A has decided they're pissed off at person B, and we can identify them and we can work with them. And mostly it's a non-coercive way. And I think crisis services have a really special role to play in that work.
Jack, you're talking about overarching data, and yet so much of what happens in our societies is driven by high-profile media frenzy around and this specific issue of violence and mental health. We've had so many examples on both sides where something has happened tragic to a person in a mental health crisis and vice versa. So I'm going to run through a few situations, and let's just get your quick thoughts on them. The first really going back to the 80s is when we had the shooting of an individual in mental health crisis, Michael Taylor, in 1987 in Memphis, Tennessee, which really led toward the establishment of CIT. Any reflections on that, Jack?
Yeah, I've had the just joy and privilege over many years of being involved in CIT training around here in Pittsburgh. I remember some of the early sort of proto trainings I got to be exposed to back in Rhode Island when I was still in college. Um, yeah, right. And part of what happened in the wake of that incident was the officers and the brass and the family sitting in a room and agreeing that this was awful and nobody wanted this to happen. And how we train our cops really matters, right? Because most of the time it goes okay, and sometimes it goes amazingly well. But when you're sending out someone with a gun to respond to someone in crisis, there's a whole different set of outcomes, right? That we have to worry about. And I think it's vital that at a national level that we do a better job teaching our cops, managing our cops on the interpersonal skills, right? If you're sworn law enforcement, you've got to, you go through training, our state troopers in Pennsylvania, amazing. I get to work with a lot of them. I'm on the Pennsylvania Citizen Law Enforcement Advisory and Review Commission. Just had a call for them earlier today. Right. They do an amazing job training, 6 months of training and just very, a lot of how do we be polite and formal and respectful, right? But also how do you de-escalate? Because the metrics that most cops across our country go back to their commanding officers with, every 6 months, they've got to go to the range. Are you still competent using your gun, using lethal force? How many complaints have you had? What's your arrest? What are your clearance? But not, are you able to de-escalate someone who's upset?
Right.
Can you have a conversation with someone who's in a crisis without cursing them out, right? Can you be around a person or a family or a group of people just raw emotion pouring out and stay calm? And that's we know that ain't easy, right? And that's a hard thing to teach in a classroom, but it's an important thing to learn. And every officer, every brass I've worked with, they want to get this better. And we've made an incredible journey since the late 80s around this. We still have a lot in front of us, but a lot of great folks working in that space.
Let's do a couple on the other side of that equation, Jack. Of course, a lot of this launched in 2007, even before Columbine. I guess Columbine was in 99, but 2007, Sung-Wee Cho at Virginia Tech. And that seemed to, I remember at the time, some of the leading advocacy groups saying, well, this wasn't a mental health challenge because they were afraid of when it seemed like it was a mental health challenge.
So, whenever you have polarized viewpoints, odds are pretty good they're both wrong, right? So it's all about mental illness, totally wrong. Our best data says most of these events are not causally linked in any way to people with mental illness, or they're not occurring in people with obvious mental illness. And then there's the other sort of extreme that says this isn't about mental illness at all. But you know what? Sometimes the people engaging these acts or the people that we're intervening with, they're really ill. They are really suffering. It really is. There's a causal nexus there, right? And a lot of times we just don't know. And what I say is, like the idea of profiling, drawing a circle around a group of people because of some characteristic. If you want a profile based on mental illness, it's incredibly unethical and it's incredibly ineffective because most of the people who go on and engage in serious acts of violence aren't going to be in that group, right? Yeah. But if you're going to instead say, let's identify people who are stating their intent to hurt other people, or have other obvious evidence-based risk factors for violence, say, oh, that person who's already made that threat to go kill one person or a lot of folks happens to have identifiable mental illness, treat the bejesus out of that. Treat away, right? Because you'll really reduce their risk, and that's good ethics, and that's good policy.
Jack, I just pulled off my shelf the Columbine book by Dave Cullen. Have you read it?
A long time ago. Yeah.
So what's your take in Columbine, Eric Harrison and Dylan Klebold, which really launched off a lot of our public awareness of all this. And yet what Cullen would suggest in the book is one of those two had significant mental health challenges and the other one wanted to murder 500 people. Yeah,
and it depends on who you talk to, right? I think if you talk to the parents, both of them thought their kids were really suffering. Yeah. What I can tell you, when we really look at the data, and by the way, some of the best data comes out of the FBI. Yeah. Suffice it to say, they have access to a lot more information than a journalist will get their hands on about the lives and histories of these folks. And in one of their data sets, where they looked at about 10 years of data, they said you know what? Only 25% of these folks had any evidence of mental illness, of like any kind of a diagnosis. And of those, only about a quarter of them actually had what we'd consider something serious, like a psychotic illness. It was a lot of depression, a lot of generalized anxiety disorder.
Right.
And a lot of people live with a lot of mental illness.
Yeah.
We throw around 1 in 6 or 1 in 4 adults.
Right.
But actually, in the past year, it's probably more than half of adults in the US
right.
have had something. It's us together.
Now, in both of these, both Virginia Tech and Columbine, those individuals died in the situations that occurred. With Aurora, James Holmes lived and was in court. And reflections on the Aurora tragedy, Jack?
Yeah, and that's an example of where the assailant lived. The assailants do not always live, and sometimes it's through police action. Sometimes part of the plan was always suicide.
Right.
Sometimes, and again, Aurora was an example. This was a person who actually acquired body armor, had pain medications that they'd taken knowing that they may well be injured in the attack. And oh, by the way, critical for our audience, called a crisis hotline. And the record said for, I think it was 9 seconds, was connected. And he said, well, I don't think it ever connected when he was interviewed by I think it was Dr. Reed, who was the forensic psychiatrist who did the assessment. And from the hotline side, they said, hey, it seemed like it never connected, right? But oh my gosh, like what if, right?
Right. Wow.
What if? And that's, by the way, why we've got to up our game in making sure our crisis programs know how to recognize and know how to better work, because what a difference it can make, right? That person, two ways of looking at it, right? And it's an anchoring bias question, right? Probably was in the early stages of a psychotic illness. And when you sort of read about what's happened since, when you even read about what happened during the trial and during the evaluations, probably had some early whiffs of a major psychotic illness like schizophrenia. And also scrupulously and meticulously planned this attack out at multiple levels. Acquired firearms under multiple charge accounts, went to different ranges to practice so people wouldn't expect a pattern, researched other shooters, had made a grid deciding what's my target going to be.
Yeah.
If I go to a school versus an airport versus a mall versus a theater.
Right.
Thinking about sort of, would people misinterpret this? Would people think it was political or school related or something else? Chose targets based on proximity to first responders and decided, ultimately the movie theater was the best choice, but it was close to the police station, and had actually set up his apartment to be a diversion to explode with multiple homemade explosive devices, with 3 different triggering mechanisms, which amazingly all failed.
Right.
As a way to draw.
Yeah. Right.
Yeah.
So even if he was in the early throes of a psychotic illness, scrupulously planned and was fully aware of what he was doing in a way that we just often don't see in people living with major illnesses because they're impaired by them.
Yeah, that all makes sense.
Yeah.
John, you used the phrase when you and I were planning this episode, the long shadow of stigma. Where do we go next, John, from your standpoint?
In what you're describing, not only are circumstances that reinforce the stigma of persons with mental illness being dangerous, and these things happen undeniably. But there's also, as David had mentioned, this long-standing fear that mental illness is associated with dangerousness and out-of-control behaviors, talking about that at the beginning of the podcast. And we know that this fear has been reinforced by the overuse of 911 and civil commitment laws in the past to coerce people into treatment against their will. And you've talked a little bit today, Jack, about things that are being done in emergency and forensic psychiatry, which, quite frankly, are really in the center, essentially, of these coercive practices, deciding whether or not to commit somebody. And now you're in this place where you are passionately trying to flip the script, so to speak, and reduce coercion and stigma in the care and treatment of people in behavioral health crisis. And I wondered if there's certain policies or practices you're seeing coming out of emergency psychiatry and forensic psychiatry that you think is really going to significantly reduce coercion and stigma over time.
It's There's a study I saw years ago, which was actually looking at stigma and bias of this violence mental illness intersection, um, and its relationship to news media coverage of some of these events. And it was from Australia and New Zealand, right? So it gives you, and I see you with your Living T-shirt there, David. Wonderful Australian-based suicide prevention program. But yeah, right. U.S. media coverage is so crappy sometimes that it's driving stigma literally on the other side of the planet, right? We've known about this for a long time.
Yeah.
So, what do we do to shift back? Part of that is just education. Part of that's just sitting down with our policymakers. Part of that is working with, media teams to sort of get the message out there in different ways, right? And realizing that the message that comes from me as the nerd, the healthcare professional might be very different than the messaging coming from someone living with mental illness, a peer, family member, something like that, right? So about 12 years ago, there's an active shooter that shot up at my hospital, killed one person immediately, 7 people injured, one of whom later died, possibly from related issues. But it's an incident. I remember the first hours after that event in the command center, we'd see on the screen, local news reporter with the earpiece saying, this just in A, B, and C, and we're like, what? It's not even close, right? It's not ABC, it's XYZ.
Right.
And so one of our media folks would call and talk to their producer, and the reporter would go, this just in, 789. And we're like, how did you get, that from that, right? But we've worked really hard to engage with our partners in media locally and nationally to change some of the messaging, knowing that not just news coverage in general, but especially news coverage after some of these high-profile events of this immediate rush to some kind of easy explanation of, if it's a person of this background, it might be terrorism. If it's this, it's just sort of everyday crime. If it's this, it's mental illness. And skin tone matters in how that coverage rolls out in some pretty disgusting and unpleasant ways. But trying to get ahead of that and saying, hey, listen, if these things were easy enough to explain with a single cause or simple explanation, we wouldn't still be dealing with them, right? That they're really complex, they're really nuanced. Don't rush for the easy answers, but bring in the experts to have the serious discussions. And by the way, there's so many amazing stories about recovery and mental health treatment that have nothing to do with violence, because most of living with mental illness, most of being a family member of a person with mental illness has nothing to do with violence.
Love all of this, Jack. And we do have situations of violence, and in this context, they are the 1 to 2% of the 5% of the, so it's, Jack, we looked up the top challenges of emergency psychiatry. So this is a rapid fire section. I'm going to throw them at you.
Yeah.
And just give us your quick response, 1 to 5. A 5 is, that's the biggest challenge I got, or 1, not so much for me. High patient volume.
I'd say it's a 3, right? Yeah, there's a lot of volume, but that's a good thing if people are getting the care.
Right.
It's a bad thing if they're sitting warehoused in an ER not getting access, but it's a good thing if we're able to help.
Limited resources, including trained staff, appropriate facility, necessary medications, that kind of thing.
Yeah, I'd say that's a 4 or 5, and a lot of that's about limited dollars for that.
Yeah. Stigma and misunderstanding.
It's a 3. It's a big thing, but in day-to-day operations, we don't necessarily notice it.
Violence and safety concerns.
In the acute psychiatric ER, it's a big one, right? Because, again, most people living with mental illness, not violent. Have I said that 20 times yet? I'll say it 20 more times, right? But there's this filter effect that what it takes to get to a psychiatric emergency department, what it takes to get to an inpatient setting, we have distilled. And part of the ticket of admission is this person so disabled by their illness that they are posing a risk.
Right.
So we get this concentrated group. And so, violence in the workplace is a huge issue. And by the way, not just in emergency psychiatry, but across healthcare. Most people who are injured from workplace violence in the United States are healthcare professionals. And that's something I never learned about in medical school. That was never in the brochure, as they say. Right.
Couple more, Jack. Understaffing and burnout.
Staffing seems to have rebound. COVID was a little scary, not just because of the COVID, but because of the huge shifts in where people worked and where they wanted to work. But we are sort of back up to full staffing. But by the way, that's not necessarily where we need to be above where we were pre-COVID. But yeah, turnover has been a huge issue. Increased wages, I think, is a wonderful thing. I know it's a tough thing on the balance sheet, but even with the increases in wages that we've been able to give to our staff, they are worth so much more.
Final one, insurance and financial barriers.
So I am really lucky because of the way my program is structured. We're a partnership not just between our medical center, but also between community care behavioral health, which is our local managed behavioral health carve out, sort of the big shark in the water there, and our county Department of Human Services. And it means that no one who's receiving crisis services from us has to worry about a copay, a bill, a back bill, or any crap like that. Their insurance covers it or the county covers it. And we are truly lucky here. But yeah, overall, when you're in crisis and you're worried about like what happens if an ambulance shows up, what happens if I need services, who's going to pay for that, right? We never expect a cop to show up and say, hey, can I get a credit card for the copay, right? You don't expect the firefighters to wait around and run your insurance before they start hosing down your house, right? Why should it be any different if you or a loved one is in crisis?
Yeah. So, Jack, this has been a terrific conversation and so important. So I'd like to end it on a little bit of a darker note. And that is, well, let's talk about the 1980s ER show. Jack, John didn't want to do this segment. John said he didn't want to do this segment because he didn't watch. Did you watch, Jack?
I watched a little bit. It was interesting because it did sort of lead to an upswell of people going into the field of emergency medicine. But yeah, I watched a little bit here and there. So honestly, I think Scrubs sort of captured the experience a little bit better.
Scrubs, yeah, I forgot about Scrubs. Did you watch Scrubs, John?
I did not. No.
Oh my God. Do you know any of these characters, Jack? Which one would you most have resonated with? Do you remember the show well enough to?
Well, people still confuse me for George Clooney, so it's the shadow that's it's the curse of my life, right? And I'm told they're doing a reboot here in Pittsburgh. It's not officially like an ER reboot, but it's the guy who played Carter is his. I don't know, but we're excited. It's Pittsburgh emergency medicine.
But this is your shot, right, Jack?
Yeah.
Well, John Draper, that brings us to the segment of our show, Absolutely True Tales of Behavioral Health Link.
Absolutely. We'll see.
Yeah. And it's in the context of these rare situations where something challenging happens. But as Jack talked about, when something happens to a person in a mental health crisis, it disproportionately falls to people of color. In my research for this, Jack pulled up not only the individual in Memphis, but 10 other top circumstances. And I was not surprised how many of them were Black men. But we're all trying to do this work in the context of the systems we have today. And it was 2 a.m., John Draper. This was, at least 15 years ago. And I was living in Atlanta, working with Behavioral Health Link. I was the CEO at the time. And we had our mobile crisis team go out to that apartment. Again, this is a fictional picture, but to go out to that actual apartment and respond to an individual. And we were not able to manage the escalation that occurred, and we were forced to engage the local police department. And they came out, and it turned into a barricade situation. So they stood down and escalated to SWAT. SWAT came out, and unfortunately, the individual charged out of the apartment with a knife and was shot and killed. So what's on the TV camera, and I've recreated to the best of my memory I was in the room with my chief operating officer and our mobile crisis team, but I had first responded to the scene that was secure. There was police tape blocking the road to the apartment. And my chief operating officer and I got there after that police tape was set up. So we're just on the other side. And behind us is the news media. And I'm saying to Pam at the time, do not turn around. Do not look back under any circumstances. Because I said, if they capture our face, we'll be on the news. Hours later, it was us and the SWAT team in a small room being pulled out one at a time to be interviewed. And every 15 minutes they showed, since they didn't have our faces, they showed our backs. And, for the first probably 2 hours, we sat on one side of that. It was a very small little room it was actually, the TV was on top of the refrigerator. But on the other side of the refrigerator was me and the mobile crisis team. And I don't know what happened, but eventually we merged and we started talking. And I really had started the evening thinking, my God, why was SWAT so quick, and then they talked me through what happened. And look, clearly they needed some kind of non-lethal weapon to stop this individual, but they did not have that. And for many reasons, Jack, it's another episode. They didn't have tasers. And again, that's a complicated equation because some individuals have died from tasers. But they talk through. And one of the things that really stood out for me, John, from this discussion was they said, you guys in mental health tend to be cavalier. And they said, here's the metaphor we want you to remember. Police officers who pull over somebody for a traffic stop. They'll do 1,000 of those without incident, but they know that one in those 1,000 is an individual with a weapon under the seat and a outstanding warrant, and it's a threat. So there has to be a protocol. And it really inspired us, John. This is back when Washington State had just done their safety summit after a social worker was killed in a home of a person with who was being treated by the system. And they had basic safety protocols, which led to things like a mobile crisis team going in pairs, the mobile crisis team having information up front about violence history. And how do we, Jack, have that appropriate utilization with those 1,000 stops, but also take reasonable risks or reasonable protocols and practices that allow us to, with dignity, with respect, also be protective of everyone. So it was a tragic situation, John, but it was one in which, I was struck by the compassion and frustration of law enforcement of these kinds of situations, and how we on the mental health, substance use, suicide prevention side, we need to learn from one another, and we also need to make sure that we have an approach where we're able to be that first response as often as we can.
Yeah.
David, I believe all that happened, but were you really there?
Yes, I was really there, John, 2 a.m. in the morning. John, this is where I usually say you were there. And I'll say, John, you were there. You were there with me in that room in Roswell, Georgia.
Been in conversations a lot like that.
Absolutely. And John, I think that brings us to some we need some plain truth, John.
Well, we've heard a lot of it today. And actually, we were just talking earlier about this incident with James Holmes in Aurora and him making this call outside of the movie theater before he walked in and committed this horrendous act of murder. And that call, as you were noting, Jack, was to the local crisis line in Colorado. And you asked a very important question. What if that call had connected? Yeah. And a few things have changed since that very dark night where 12 people died in that mass shooting. Following that horrific incident, I think, Dave, you've mentioned in the past that Governor John Hickenlooper signed a bill that created a statewide crisis call hub and a comprehensive crisis care system. And most of the 988 calls to the Rocky Mountain Crisis Partner Center are now connected to a counselor within 15 seconds. That's great. And more people in desperate need to speak with a mental health crisis counselor can readily recall and dial that national 3-digit code. And doesn't matter where you are in the United States, that can happen. They can answer right now in about 41 seconds. So another change, though, tragically, is the ubiquitous nature of mass shootings in this country, now numbering nearly 2 a day. In my prior role as the director of the National Suicide Prevention Lifeline, our primary mission and priority to prevent suicides was clear. Although it was not frequently discussed, the service's potential for preventing harm to others was also apparent to me. And in general, research is clear that persons who are threatening others are more likely to die by suicide than commit homicide, and high risks of suicide are commonly seen in persons assessed to be at risk for harming others. But specifically with mass shootings, researchers have noted that suicide and life indifference is one of the 3 factors common to all perpetrators of mass violence. A 2004 report from the U.S. Department of Education and the Secret Services stated that 78% of school shooters were known to be suicidal first. Now, experts have described school shooters as suicides with hostile intent, and they agree that mass shooters expect one of 2 outcomes from the rampage. I'm either going to be in prison for life, or I'm going to be dead by law enforcement or my own hand.
I will say that's an oversimplification. And I will also say it's also not far from the truth. What we know is when we look at, and then there's maybe 20 good data sets out there of mass shootings, and all of them have sampling bias errors. And again, emphatically, violence, the trend in our country for violence in general, it's headed down. And even though we've had a surge of mass shootings, they're still very rare. It's a small part of the overall puzzle, and they seem to be trending down this year as well. But what we know when we sort of do these different sampled studies, most of them aren't mentally ill, but most of them have crisis. And when I say most of them, 87% in the Violence Project data set, 98% in an FBI data set, 100% in the Secret Service data set. I mean, these are really high numbers, right? We know that a large number, somewhere between 30 to 80% of these folks seem to be suicidal. And again, so we've got crises, suicidal, not an obvious mental illness. I don't know about you guys. I happen to know a hell of a lot of really amazing professionals who are amazing at working with people compassionately and effectively who are in crisis, who might be suicidal, who don't necessarily have an obvious mental illness, but who are reaching out for help. Right. And I think that's the window of opportunity we have here, right?
So if you'll bear with me, I'm going to go back a little bit. So specifically with mass shootings, researchers have noted that suicide and life indifference is one of 3 factors common to all perpetrators of mass violence. A 2004 report from the U.S. Department of Education and Secret Services stated that 78% of school shooters were known to be suicidal first. Experts have described school shooters as suicides with hostile intent. They agree that mass shooters expect one of 2 outcomes from their rampage. I'm either going to be in prison for life, or I'm going to be dead by law enforcement or by my own hand. Thomas Joyner described murder-suicides as a perversion of virtues in his 2014 book of the same name, saying that these are suicidal individuals who are seeking mercy, justice, duty, or glory before they die. So here's the good news. Our 988 crisis counselors and mobile teams are in a potentially good position of preventing violence to others because we're already primed to prevent suicides. But we're not necessarily primed to assess and manage risks for harming others like we are for helping people with suicidal thoughts. And to realize that potential, our crisis counselors have got to be intentional, capable, and caring in our efforts to identify and help people who could bring harm to themselves or others. The 988 Lifeline has national standards to guide counselors in their assessment of persons who could be suicidal, but no such standards are in place for violence assessment. So when I was the Lifeline, we brought Jack in to help us in 2019 to develop recommended approaches for crisis counselors working with people who present a risk to others. And Jack's consultation was so important, and it led us to developing a tip sheet for violence and threat management for network centers in 2022. As I mentioned earlier, we also brought Jack and Thomas Joyner in to consult with us at BHL on our development of our software platform, which is now being used in several states. But there's some differences in assessing and helping persons who present risks of violence as opposed to suicide risks only, such as this duty to protect, as you were noting about earlier, in terms of telling third parties in the event of a known threat to an individual or group. But a very real concern for crisis counselors assessing for harm to others is the potential for overprescribing invasive interventions like sending out law enforcement. We know that just because a person says they want to die doesn't mean they're going to kill themselves. Data shows that for every one person who dies by suicide, there's another 316 who think seriously about killing themselves but don't do so. I would assume there's a similar or greater difference for thoughts about killing others in actual homicides, as suicides are nearly 3 times more frequent than homicides. And another thing we know, and it's true of deterring acts of violence as opposed to suicides, people do often fear that committing violent acts are going to make things worse for them in their lives. So in any case, counselors must be trained to help people who are presenting such risks to seek alternative approaches to addressing their hurt, fear, or grievances in ways that don't make things worse for them. So just to be clear, preventing suicides and resolving behavioral health crises must be the priority for 988 Crisis Services, since the overwhelming majority of persons who are suicidal are a threat to themselves and not to others, as Jack has so eloquently noted during this episode. And it's also important to remember that most persons in behavioral health crisis are neither a danger to themselves or others, and helping them before things get worse is the prevention and aim of crisis work, also as Jack was noting. But it's also true that if our counselors are equally good at identifying behaviors of our callers and clients that put themselves and others at risk, our crisis services could better promote both public health and safety. In addition, the better we are at identifying potentially harmful behaviors of all kinds, the more we can learn, develop, and innovate on effective ways to prevent violence to self and others. So one last story. In 2006, a popular television show for the school-age demographic was One Tree Hill, and they planned to broadcast an episode where a high school student was thwarted in his plan to shoot up a school and kill himself. Now, before the show's broadcast, their publicist called us at the Lifeline and said, look, we want to put up a PSA, and maybe that can get people to call if they're feeling like this individual that we're going to depict is feeling. And that PSA led to a spike in calls to the service, and one of those callers connected to a crisis center in Colorado. The caller was a young man who told the counselor they planned to shoot up his school and kill himself. The counselor empathically engaged him, helped him to feel less alone, and collaborated with him to agree to receive a visit from law enforcement. When police arrived, they discovered a store of firearms and ammunition and brought that young man into custody. The counselor later testified at his hearing where the young man was remanded to a treatment facility towards finding a hopeful and more better life. It is not a stretch to say that this young man's decision to reach out to Lifeline in 2006 and the counselor's outstanding work on that call made the difference in saving his life and the life of several others. Could our crisis services be better trained and prepared to identify persons threatening harm to others as well as to themselves? And if so, could we better collaborate with them more effectively to keep them and others safe? I believe it's worth a try. David, that's a wrap.
John and Jack, that's some plain truth and a real lifeline. Huge thanks today. Jack, all the expertise and passion and experience you're bringing to this really critical convergence point in emergency psychiatry, crisis services. We love it. And thanks so much for spending the time with us. We hope all of you will join us next week when our guest will be a dear friend and inspiration, Craig Miller, who's also featured in our documentary film, Moving America's Soul on Suicide. So thanks for letting us draw you in again this week. Come back next time as we continue to navigate the currents of the crisis care system. Until then, remember, every call, every life, every story matters. Stay connected, stay supportive, and we'll see you on the next Lifelines.
Thanks, Jack.
Thanks all. Stay safe.